Hi, and welcome to the 5-Minute Check-In. Well, today is going to be a fun discussion, at least for me, because we get to talk to a good friend and colleague of mine, and I get to hand over the reins of hosting the podcast to my other dear friend, Associate Professor at Creighton University, our Vice President for Clinical Standards, Dr. Ankita Sagar. Ankita, you are now formally in charge of the podcast.
Amazing. And I'm very, very happy to be here because, like you said, this is a very special episode. We're going to take a little bit extra time to talk about a very hot topic, which is how do we use AI in clinical world and what does it mean? How do we interpret things? So to help us do that, of course, we have Dr. Tom again, and we have a very special guest, Dr. Farid Foroutan, PhD, Associate Scientist at the Ted Rogers Center for Heart Research in Toronto, Canada. And his special asterisk is that he's trained in clinical epidemiology and biostatistics from the McMaster University, also known as the home of evidence-based medicine. So welcome, Farid, to our podcast.
Thank you for having me. This is super exciting.
Perfect. Thanks for coming. Now, Tom and Farid, I know you both know each other from before. So tell us a little bit about the story of where you met and how did this end up being a partnership?
Well, I'll start. So Farid and I had the opportunity to teach together. I taught up at McMaster University in their international EBM course for probably now almost 30 years. And we always have a tutor trainee. And I was lucky enough to have Farid work with me on teaching international students on concepts of evidence-based medicine. And Farid was actually smarter than me, so I was happy to have a tutor trainee who knew more than I did. So that's how I remember Farid.
I think I'm the lucky one. I walked into the room, there's this person with the New York accent being super lively and getting everybody involved in the teaching process. Lots of great teaching examples from Tom. So that was such a pleasure to be able to work with him and that opportunity.
Yeah, we had some good fun.
Excellent. There's always more stories there. So we will have to unpack some of the lighter stories later in our podcast, perhaps. So, Farid, tell us a little bit about this wonderful BMJ guideline that you published, and there's so many aspects to it, but give us a summary. What should we think about? What was the problem statement and what should we take away?
So there's a backstory to this work, and it goes to the origin story of Tom and I as well. Long time ago, we were tasked by UpToDate to come up with a framework for evaluating some of these artificial intelligence technologies or predictive models for clinical practice use. And the framework that we came up with didn't come to fruition. So fast forward, we brought that same approach to this guideline. And the topic of this guideline is a piece of technology that's often used in colonoscopies amongst individuals for example, going for colorectal cancer screening. And the tool is supposed to just be applicable to the physicians who are doing the examination. And as the images are coming through, it draws a little green box around spots where the physician might have to pay a little bit more attention to because it might be of interest. It's hugely studied. It's one of the areas of medicine where there's a lot of studies on it. There's over 40 trials that have been done on this piece of technology alone. And our task was to put together a panel of international experts to look at this evidence together and see if folks should or should not be using this piece of technology on their day-to-day practice.
I mean, it's amazing there's that much data on an AI tool, yeah, it's crazy, really.
Yeah, I was going to say, wow, that's a lot of studies, and it seems like a lot of studies that were done pretty rapidly, maybe even in parallel to each other, to digest all of this data.
Yeah, just to pick up on that, I mean, like the first time that we tried to look for the evidence, we found 20, but then a year and a half later, that number doubled to over 40 studies on this topic. So it was a heavily evolving, rapidly growing field.
I think what was interesting about what Farid pulled together was an international consortium of expert clinicians, actually also patient thought processes and evidence experts. So, that's what you want. You want all three. EBM is the mix of evidence, patient preferences, and clinical experience. So it was really a great panel, and he led it beautifully.
Amazing.
And so the thing that we found from doing all of this work was that when we looked at the totality of all the evidence that's available on this technology, unfortunately, it doesn't move the needle that much in terms of preventing colorectal cancer or even preventing or reducing death from colorectal cancer. You have to follow people for a very long period of time, and the amount of reduction you see, it's so trivial that most people on our panel felt that it's not worthwhile to make a recommendation for its use. So we went for a suggestion against this use daily practice.
So for the average physician or APP, or even let's say my neighbor who is at home watching this, what is the high level takeaway? So when we think about this clinical tool that happens to be placed in colonoscopies, what's the takeaway?
So right now, it's just perhaps not to go out of your way and really definitely want it. If it's there, it's there. If it's not there, you're perhaps not losing out on much. And then so the amount of benefit that it could have to you, it's super, super small.
Yeah, and I would also, what it teaches us is about colonoscopy. So I would say, let's assume this is just, it's not helpful. So part of me also worries sometimes, could these tools misguide experts that are clinicians? So my leaning on this was really just, stick to the tried and true until we figure out, AI-assisted colonoscopy is doing a better job. And the bigger picture is, hey, AI is not evidence. AI needs to be validated for its evidence, and it may not actually be beneficial. People think AI, evidence, not the case. So the other big message to everyone, physicians, lay people, is when you hear AI, do not believe it's actually accurate. You have to validate that.
Very similar to other tools that we validate and we make sure those guidelines are actually getting us the outcomes that we want. I want to delve into just a little bit more on the idea of a living clinical practice guideline, which to me is just phenomenal and something that we all aspire to. So Farid, do you want to tell us a little bit about what is a living clinical practice guideline and how did you approach this?
I'm so glad you're bringing this up. It's for us, it's a tool for us to be able to stay on top of the evidence that's ever evolving and rapidly growing. So like I said, in a span of a year and a half, the amount of evidence that we had on this tool doubled. And so you can just only imagine that as time is going by and more people are evaluating this technology. So the idea for a living guideline is for us who are responsible for pulling all the evidence together is to stay on top of that and make sure that if any time the amount of information coming in starts to change the conclusions that we draw from it, to actually take that back to our panel and say, hey guys, like let's take a look at this now. The messaging is a little bit different, or it could be different. Are you willing to make a different recommendation than what we had before? And so as opposed to the old ways of just doing it once, people put it as a PDF, forget
never
about
see it again. Yeah.
Exactly.
So Tom, I know you and I have talked about this also because internally at CommonSpirit we do some of this work. We make them living documents. We review them at a certain cadence and change things if things need to be updated. And in your framework of, being an expert at predicting modeling, thinking about evidence, how to be applied, what are your thoughts on living clinical practice?
Well, it really, you and I talk a lot about living, a learning health system is a system that's constantly looking at its own data and trying to understand the evidence behind that. So I think this fits into that model, and the infrastructure we are currently trying to get our hands around to make that happen it's always a process. I also think it, back to just the AI, that we are as a health system fully engaged with AI and using it where we can. But we're also saying to ourselves, as that model gets closer to the bedside, closer to the clinic, we're going to up our bar for what the evidence is in order for us to deploy that tool. And I think that's critically important. You can be both embracing something like this, but also doing it in an intelligent way at the same time.
Yeah, perfect balance of aspirational, but also practical and evidence-based. I love it. Well, thank you so much for allowing me to host this very special episode of 5-Minute Check-In. Thank you, Farid, for letting me interview you. And then Tom, I'll hand it back to you.
Great. No, just thanks again. What a great opportunity for you to spend time with Farid, who's just, brilliant at this. I mean, if you saw Farid managing this panel from across the country, it was really quite an interesting process, but really what we need to do more and more and more of. So Farid, thank you for everything you do, and thanks for joining us.
Thank you for having me, and thanks for allowing me to present on behalf of the international group that led this effort.
Great. Thanks, everyone. And we'll see you at the next 5-minute check-in.